community. And we will also provide you with the slides at the end of the call as well. So without further ado, we will get started with today's webinar on creating community clinical linkages, leveraging partnerships, and funding to reduce disparities in hypertension identification and control. Pardon the year there, it should say 2016, but it does say 2015. So thank you all for joining us. Today's webinar objectives, what we're hoping to do is to describe the ASTHO Million Hearts Learning Collaborative and our national partner network. We have not been able to do this work without the help from our national partners, who we appreciate working with so closely to provide our states with the level of support we've been able to do to address and define community clinical linkages within their states and local communities. And so we'll also have examples from our state and local communities to demonstrate how community clinical linkages have helped them reduce disparities in hypertension identification and control, and then how they've been able to develop different partnerships, leverage that work through worksite wellness programs, for example, and even linking this heart disease and stroke work into their community planning processes going forward in order to sustain all of the lessons learned that they've been able to identify in the Learning Collaborative. And then we'll also have states demonstrate how they have continued to address hypertension by leveraging other resources and funds available to them. So our current Learning Collaborative states include the states in front of you: Colorado, Connecticut, Wisconsin, Arkansas, Texas, Indiana, and North Dakota. And so they are continuing their work that they have started with the ASTHO team. We have been working very closely with them throughout this year on continuing their work plans. And for just more general information about those states and what they've been able to work on, feel free to visit our Tools for Change website or reach out to any member of the ASTHO team. We're happy to connect you all on any opportunities to partner with them. So now we will actually hear from our national partners on the line who have some really great information to share with you all. So I will turn it over first to Jen Cooper at APHN. Jen?
Thank you, Alicia. Can you hear me okay?
I sure can.
Okay, good. I wanted to make sure I wasn't on mute. Thank you. So let me tell you a bit about APHN, or the Association of Public Health Nurses. And Alicia, I'm trying to advance to the next slide, but it's not letting me, so maybe you could do that for me.
Sure.
Thank you. So APHN is a membership organization, and we represent practicing community and public health nurses. And I use both terms because we have some of our nurses, probably a majority of them, in the governmental public health setting, but also nurses that are working out in the community that we represent as well. We have approximately 260 members, and they're represented in all 50 states. We're also proud to have regional reps in the 10 HHS regions. We follow the HHS region model, so we have a public health nurse representative in each of those regions. We're proud to be partners, and I wanted to tell you a little bit more about our partnerships and the work that we do. First of all, APHN is part of the Public Health Nursing Quad Council. So that includes the American Nurses Association, the Association of Community Health Nurse Educators, which are our educators that are educating future nurses, and then also APHA's Public Health Nursing Section, and the National Association of School Nurses. So we are part of that Quad Council, and then also, besides our great partnership that we have with ASTHO and NACCHO, we also work closely with Region 7, which covers Iowa, Kansas, Missouri, and Nebraska, and their Public Health Training Center. We have done some diabetes prevention work with them. We have a new partnership with the National Association of School Nurses, working on chronic disease management in schools. And we also have another new partnership with the American Association on Health and Disability, working in Washington, D.C. On breast cancer screening and awareness. And that's an initiative specifically targeting women in certain wards of D.C. with disabilities. So we're happy to have those partnerships as well. And next slide, please. As far as what the community clinical linkages look like for our organization, it's really promoting those linkages between nurses. They seem to have the relationships. And we know as an organization that nurses represent the largest percentage of the workforce, both in public health and also in the healthcare system. So trying to connect our nurses in public health roles, a lot of them in local public health, and having them connect with nurses who are in acute care settings, hospitals, health systems, also primary care providers and in settings that they work in, such as community clinics, and even in long-term care facilities. It also is connecting nurses in local public health and doing collaborative work with nurses in community agencies. And one really exemplar from this project with Million Hearts has been local public health nurses connecting with faith community nurses in their community settings to work on identifying those with hypertension and how we can best help them manage their hypertension. And the next slide, please. Just to give you an idea of APHN's contribution to reducing disparities in hypertension identification and control, what I did here is we just try to show you a little bit about what our mission statement and vision is, and we work to support nurses within their role in population health, whether it's in public health or in a community role. And we kind of organize that into 3 areas related to our mission and vision, which generally is to shape that role of public health nurses within the practice of population health. So in practice, what that looks like is making sure our nurses are involved with and understand community assessment and looking at more than just the clinical, which they understand very well, but also the social determinants of health. And then also doing health monitoring and coaching, which is a good role for them within the identification and control of hypertension, and also educating them on proper techniques for taking blood pressure, which we all do need to have a refresher on now and again, so that's important too. So nurses in the community are really likely partners to provide health coaching and monitoring related to hypertension. As far as leadership, we hope that our nurses would be able to create strong partnerships, not just within their own organizations, but to link with nurses, like I said, in primary care, healthcare settings outside of public health. And then what they're doing in those partnerships are promoting practice and systems change, so we don't let people kind of fall through the gaps, and we can connect them better to what they need to help manage their chronic conditions. And then, of course, advocacy. We do advocacy to promote the role of nurses in public health and in community settings, and also their role in population health. So that's just a bit about the Association of Public Health Nurses. I'm glad to answer any questions later on, but if you'd like to learn more about our organization, you can go to phnurse.org. And I thank you for your attention today.
Great. Thank you so much, Jennifer, for your presentation. I really encourage the states to reach out to Jennifer directly or any member of the ASTHO team if you have further questions related to her presentation today or just working in the future to help sustain all of the wonderful work you all have been able to do thus far. So at this time, I will now turn it over to my colleague at the National Forum, Debbie.
Thank you. Can everyone hear me fine?
Yep, you're coming through clear.
Perfect. So I just want to give a brief overview of what the National Forum is, and myself, I'm Debbie Martinez, the Program Manager for the National Forum. So the National Forum is a DC-based nonprofit that brings together the most dynamic and diverse organizations in cardiovascular health prevention, providing a forum and outlet for organizations to really amplify their voices. We have more than 85 members that work together to advance solutions that improve heart health at the community, state, and national levels. And we really accomplish this in two ways. First being that we enlist our member organizations to amplify, and then we convene complementary players to develop and lead initiatives targeted at specific cardiovascular diseases. And with that latter, it's kind of what I want to focus more so on, because I think it provides great examples on how we can create these community clinical linkages and how the National Forum can assist other members. So one of the first things is that we have it's not an extensive list, but we do have a small directory of contact expert assistants, so people who can look into their organizations or them themselves can come and present at a meeting or something, such as we have the Association of Black Cardiologists. They have been able to provide speakers in the past and so forth. And we also have the Stronger Hearts Best Practices Award Program, which right now we're trying to look at heart failure initiatives all over the United States that are really working within the community to be able to showcase their efforts, and those who are selected will be offering a $1,000 award for two award recipients. But what I really want to focus on are two initiatives that we've been working extensively on for the past couple of years, which is Move with the Mayor and Counter Cholesterol. Move with the Mayor is something we started about 3 years ago, and it is an event that we do the month of September leading up to World Heart Day that we are in partnership with the World Heart Federation. And what we attempt to do is bring mayors together to lead walks with their constituents in order to raise awareness about cardiovascular disease, so that on World Heart Day, which takes place on September 29th, they can have a big celebration. And over the past few years, we've been able to create quite a bit of momentum. That this past year, we brought on 5 mayors, one from Green Bay, West Chicago, Oklahoma City, and Lorain. And it's a really wonderful thing what the mayors can do, because they are at the level where they can affect policy change, but they're also at the level that they connect so well with their community. The mayor from West Chicago, Mayor Ruben Pineda, actually had over 200 people come out for one of his walks. Another one drew 150 people, and that was during a rainstorm. He brings out a lot of school children, people from the university, all over the community to engage them on talking about cardiovascular health. And one of the important things about it is that they don't do it alone. They really work with other institutions and organizations with their community to be able to educate residents. So they worked with local public health nurses to be able to provide blood pressure screenings. They were also able to do cholesterol checks for World Heart Day. And so for us, it's been really important to connect mayors with other local organizations, whether it's a local health system or it is something as the local American Heart Association chapter, so that they can work together to really educate the residents. So mayors for us really play a key focal point in being able to educate people, especially in communities that are hard to reach. And that, like I said, this past year we were able to create such big noise and excitement. We had over 300 media shares across the United States. We were actually #1 among countries that participate in World Heart Day for media coverage. Our thunderclap, which is something that is shared extensively over social media, reached 750,000 people. So we hope that in the coming year we can bring on at least 10 cities and bring on major health systems, as well as work with more local public health centers to be able to educate residents better on hypertension, on diabetes, and cholesterol. And another initiative that we've been working on that has been piloted in the city of Austin is Counter Cholesterol. And we've been working extensively with the public health department there to create messaging tools that are aimed at women to get them to talk about their cardiovascular disease as well as their cholesterol risk for cardiovascular disease. And one important thing for us when working on this initiative in Austin is that to make it successful, we've been having to work with various different agencies and organizations, from the local YMCA to a housing community to other organizations that provide health education and access to health services. And we've been also teamed up with other organizations that work on hypertension and diabetes to create coalitions together, because cardiovascular disease prevention isn't just one cause. So if we look at the comorbid illnesses and we work together, we notice that we've been able to have a greater impact and a greater reach working within the community to raise awareness. So this project itself is still in the piloting phase, but we hope to go to 2 new communities in the coming year, and after that offer our communication tools as well as our how-to guide on how to work with other communities in your area to be able to promote prevention of high cholesterol treatment and management. So that is something that we hope to come back to you all and be able to share once it is released for the greater public. All of these initiatives are found on our website, nationalforum.org, so you can learn more about it. Or if you're interested in partnering with us on any of the local levels, for say Move with the Mayor, we're more than happy to partner with anyone who is interested, or if you'd like to learn more. So please reach out to us. Thank you.
Awesome, great. Thank you so much, Debbie. And again, to everyone on the line, for those of you that may have just joined us, we are recording today's webinar. We'll make the slides as well as the recording available to you after the live event. And then if you have questions or comments for any of our presenters today, we're taking those through the chat box. So next up, we will have NACCHO. Megan?
Sure, thank you. My name is Megan Jordan. Can you hear me?
We can hear you just fine. Mm-hmm.
Sorry about that. My name is Megan Jordan, and I'm the Director of Community Health Promotion with NACCHO, which is the National Association of County and City Health Officials. NACCHO is a nonprofit based in D.C. We're the national voice for approximately 2,800 city, county, metro, district, and tribal local health departments across the nation. NACCHO seeks to improve the public's health while adhering to a set of core values: equity, excellence, participation, respect, integrity, leadership, science, and innovation. NACCHO supports efforts that protect and improve the health of all people and all communities by promoting national policy, developing resources and programs, seeking health equity, and supporting effective local public health practice and systems. So the question is, how do local health departments affect community clinical linkages at the local level? Local health departments are really uniquely positioned across the United States. In each of the presentations so far, we've heard a lot of conversations around connecting the dots in order to affect hypertension rates within communities, and that is one of the primary roles that health departments serve. Health departments serve as what we like to call a neutral convener to support community clinical linkages. What that means is some health departments have clinics within them, some don't. And so the health departments that do have clinics can offer clinical services to also support hypertension reduction, but all health departments can serve as a neutral convener that helps connect pieces of the system. So if we have a provider who wants to refer somebody into a chronic disease self-management program, the health department can connect the dots. The health department can find providers who are interested, can find community-based organizations to offer the program, and can help facilitate the program, can help market the program. Health departments have something called community health assessments and community health improvement plans, which Alicia mentioned at the beginning of the presentation. These are on a 3 to 5 year cycle, and it's where the health department convenes stakeholders from all across the community to collect data. I'm sorry, DC is noisy. To collect data from the community to look at different health indicators, and then work with the stakeholders at the table to implement evidence-based interventions, such as the ones recommended by Million Hearts. So hypertension reduction is integrated into the community health work plan, and then stakeholders and the health department work through the improvement plan over the next 3 to 5 years, with the health department serving as the facilitator to make sure the improvement plan gets done. The improvement plan also touches on social determinants of health, which someone spoke to recently. So when we're talking about social determinants of health, we're talking about what causes health outcomes at the root level. And so in this case, we'd be looking at access to health care, access to nutritious foods, access to physical activity. And those things will also be integrated into a community health improvement plan to affect hypertension. Health departments, through this process, help assess and leverage existing resources What that means is if there are classes happening, for instance, at a library, and health classes on hypertension, and community members are expressing interest in the classes, the health department could serve as a facilitator to either secure transportation from the neighborhood to the library or to help move the classes over toward the neighborhood. Health departments sponsor and host screenings to identify people with chronic diseases such as heart disease and diabetes and connects them with services and tools to help them manage their disease and maintain a healthy lifestyle. And as I mentioned, some health departments do provide clinical care for patients who generally are not insured. How do health departments reduce disparities at the local level? Health departments collect and or provide data to drive planning for community clinical linkages. And what this means is health departments, in their role as health strategists through that community health assessment and improvement plan, help stakeholders understand where the areas of greatest need are in the community so that the stakeholders in the health department can be strategic about where they provide their resources, what those resources are, and what those resources look like. So if you have a neighborhood where you're seeing high rates of hypertension and the neighborhood is traditionally Hispanic, the health department will identify that neighbor, help you identify the population, and help you target your resources in a way that they're culturally competent. They will work with the neighborhood to understand the neighborhood's needs and then work with the providers of the resources to make sure they meet the neighborhood's needs. This extends past just providing resources into any education and marketing campaigns. Health departments do position themselves to be able to assist in ensuring campaigns are culturally competent and meet the needs of the community. This is my contact information if anybody would like to contact me. I implore you to go visit NACCHO's website, www.naccho.org, to find out more information on how you can work with your local health department to join their stakeholder group as you work on implementing Million Hearts initiatives.
Great. Thank you so much, Megan, for that wonderful presentation. Again, another reminder, if you guys have questions or comments for our national partners, feel free to drop those right into the chat box. They've been engaged with ASTHO and working with us. We've been sharing your progress on your heart disease and stroke work throughout the year with them. So they're fairly familiar with a lot of the work that you're doing and can certainly be available to help connect you with the network members at their organization. So thank you, Megan. And last but not least, I will now turn it over to our partners at NACDD.
Thanks, Alicia. This is Julia Schneider. I'm a consultant on the cardiovascular health team at NACDD, and I will be splitting this presentation with my colleague Miriam Patinian. And we're very excited to be working with all of these great partners on Million Hearts. Most of you are probably familiar with NACDD, the National Association of Chronic Disease Directors. We have more than 6,500 members nationwide in the U.S. and the territories. NACDD works to reduce the impact of chronic disease on the American population through a variety of ways by advocating for preventive policies and programs, encouraging knowledge sharing, and developing partnerships for health promotion. We provide expertise, training, and technical assistance to chronic disease directors and their staff, and specifically, the CVH team works with the Domain 3 leads in the state. And while NACDD works on a broad range of areas, anywhere from arthritis to lupus to cancer, we'll focus today on the work that we are doing related to clinical community linkages in hypertension identification and control, and share some of the stories that we've heard from the state. The purpose of the CVH project at NACDD is to really provide some innovative opportunities for state health departments to support health systems change and support the goals of several federal and national initiatives from the Division for Heart Disease and Stroke Prevention, and we work closely, obviously, with Million Hearts and the CDC 618 initiative as well. So NACDD works to share what other states are doing through a number of different modalities, and that includes fireside chats, which we launched last year and will continue to do this year. We do follow virtual roundtables, which allow states to have conversations following webinars and fireside chats. There's a number of communities of practice and what we are now calling gear groups to generate, educate, activate, and respond. And you'll hear more about that on the next slide from Miriam. So all states are addressing community and clinical linkages in some way, in part as a result of their state public health action funding from CDC. And what we've seen is work in a number of areas and buckets, and we've been collecting state stories and examples and obviously featuring these areas through our learning modalities. Self-management, state health departments are making connections with communities for not only hypertension identification, but also for hypertension management. Some community partners have been able to provide low or no-cost home blood pressure monitors for patients with diagnosed uncontrolled hypertension, and we've seen examples like in Nevada where they used funds from 1305 to work with a community health worker to participate in a pilot program. And that CHW met with patients to review how to use a blood pressure cuff appropriately, provide material regarding the importance of maintaining blood pressure control, and reviewed daily blood pressure recording logs. And Nevada is currently expanding this program to additional sites and has received cups donated by the American Heart Association. They are also having conversations with their SIM about coverage and talking to health plans about having it as a worksite wellness initiative and have it covered for state employees. For bidirectional referral, the NACDD diabetes team has conducted a series of communities of practice related to the diabetes prevention program, referral, and reimbursement. We've also heard from the Massachusetts Department of Health, who received a CMS Innovation Grant and has developed a gateway referral system, which is an open source software they are piloting in 3 FQHCs. And we'll actually be working with them on sharing some of their success in the next year as well, and we'll keep you posted on that. There's also a lot of work being done with healthcare extenders, and many states are working to support community health workers and pharmacists as part of the healthcare team. And NACDD has a project that we're doing with CDC to support the implementation of the pharmacist patient care process and collaborative practice agreements. We've seen work across the country, and one state we've seen in Iowa, the Iowa Department of Public Health has been working with their College of Pharmacy to recruit pharmacists and medical provider teams. And they've been developing resources, facilitating team meetings and trainings, and monitoring the work of these teams. And they've trained about 35 to 40 teams over the years and continue to work with new practices each year. So we've seen a lot of great work done across the country, and many of these examples are available on our website. And I know Alicia's going to be sharing a document that we put together with links and information to some of the resources that NACDD has in terms of sharing these state success stories. And I will hand it off to Miriam now for the next slide.
Great. Thank you so much, Julia. So I just want to make sure you all can hear me.
Yep, we can hear you.
Oh, Alicia,
Great,
can you advance the slides? I'm so sorry, I don't think you advanced. Did you advance the slides? Thank you.
Great. So I will just follow up on a few of the things that Julia has mentioned. I'll talk in a little bit more detail about a couple of examples. So I think in all of the work that Julia mentioned, I think what we see is that the states are addressing disparities in each of those areas around self-measured blood pressure monitoring, around identifying undiagnosed hypertension, around how team-based care can be used to reach populations that have a higher burden of conditions. Some address disparities by focusing on community work, and some focus on health systems that have a higher burden of populations that are more affected by risk and disease.
So a couple of examples that I just wanted to mention. Julia had mentioned GEAR groups, and GEAR stands for Generate, Educate, Activate, and Respond. This is a project that NACDD has been involved with. We just wrapped up a series of GEAR groups at the end of the summer, and these are groups that are focused on particular topics. And so, for example, there was a topic this previous year on addressing the payment reform so that states could understand that and how it impacts them and health systems. This year there is a GEAR group application that has been sent out by NACDD, and we're happy to share that with you if you don't have it yet. So these GEAR groups will be focusing on communicating the value of public health. There's going to be 5 groups, and 4 of the groups will be addressing communicating the value of public health in the context of each of the 4 chronic disease domains. The 5th one, however, is one that I think is pertinent for this slide. The 5th will be communicating the value of public health, looking through the lens of health equity. So I believe you have a link there to learn more about the GEAR groups, and it has a link where you can apply for those. And then I'll mention too, we have been talking with South Carolina. They have a hypertension initiative and stroke belt elimination initiative, and they're working with about 500 primary care providers across more than 90 practices. And it looks, and they have a population of patients with hypertension that's about 110,000. And they have been working on extensively on improving hypertension control and cardiovascular health. I'm excited that in February we have invited Dr. Brent Egan from South Carolina, from the Medical University of South Carolina, to host him on a fireside chat to address health disparities in identifying and controlling hypertension. And he is the person who leads the hypertension initiative. We also will have a couple of staff from the South Carolina Department of Health and the Environment Office of Health Equity who have worked closely with Dr. Egan, and will learn more about their project and share that with everyone who participates in that webinar. Thank you.
Wonderful. Thank you so much for those wonderful presentations. If you all participants on the line have additional questions, I just want to repeat that we will make these slides available to you following the webinar along with the recording. And then if you need any assistance in connecting with any of our national partners, just let any member of the ASTHO team know, and we'll make sure to get you connected. Now I'm going to quickly kind of run through really the framework of ASTHO's Million Hearts work that many of you are already familiar of. But really just want to reiterate these things as we move into an arena of really focusing on sustainability. You all have been able to garnish lots of lessons learned from this work, learning about different ways to communicate this work, learning about different leaders to engage in this work, and how to fit in the initiatives of this Million Hearts work into the vision and mission of other organizations that operate with some of your same target audiences throughout the community. You've also identified policy changes and data and different payer partners and other community level resources to all be moving and working with you in this work to improve how your state identifies and controls hypertension, particularly in disparate populations. And all of that work will be so important to continue to do, particularly as we're now sort of in front of a new administration and looking at funding and leveraging existing resources in different ways, cross-collaborating across our state and local health agencies to see how we can leverage some of the work that's being done in other areas and include this work in that, partnering with our tobacco prevention partners and maybe there's diabetes prevention partners that we can partner with to look at these things, because as we know, of the population, half of the adults in the U.S. really suffering from chronic diseases, and of those suffering from chronic diseases, many of them suffering from multiple. So there are opportunities definitely for our organizations to partner within. And then this is just a map of our Learning Collaborative states and territories and freely associated states that you all are aware of. But this is just to show the breadth of all of the examples of this work that we have, and how we can utilize that to continue efforts going forward. If you all are looking at this map and wondering about any of the work of the states that may be similar to your state, either demographically or economically, politically, and you want to kind of see what were some of the lessons learned and challenges that they may have faced and how they overcame those things, feel free to utilize and continue to utilize ASTHO's Tools for Change website to reference those success stories. These, again, are our national partners, who many of whom you've just heard from, but others listed there that are connected to this work and dedicated and committed to sustaining their heart disease and stroke-related work. As you all know, our goal through our Learning Collaborative has really been focused on blood pressure control. But as you see there, those 4 initiatives are really a part of this Million Hearts initiative overall. So there are definitely opportunities to partner with our nutrition partners and our tobacco partners to continue these efforts as we look forward in building out and putting into action our sustainability plans. Some of our project goals here that you all are familiar with. One thing that the ASTHO staff is definitely going to be reiterating and continuing to work with our states throughout the rest of this grant year is how we take these project goals and incorporate them into a system, a health system, so that these things can be sustained beyond the funding associated with this initiative specifically, and then other ways that you all might have ideas about continuing this work through other funding streams that are available across your agencies. These are just some of our strategies. Reiterated again, you all are familiar with this work, but definitely the engagement of our community health workers and community pharmacists are going to be more and more important to do in order to sustain this work and really affect the health system that all of these folks kind of have to navigate through in order to get the services that they need to control their hypertension. And then ensuring that we facilitate that bidirectional referral systems the best way that we can with the resources that we have at the moment. And then definitely before we close out this grant year, refining those systems in any way that we can while we have some funding that can possibly affect the way we do that, so that those things can continue to go forward beyond just this grant year. Again, a reminder, you all have seen this diagram probably more times than you had bargained for, but just to reiterate, this Plan, Do, Study, Act model, it should definitely be incorporated in your sustainability plans when we think about your heart disease and stroke work going forward. You all are now more familiar than ever with implementing this rapid change model and into your work. And it will be interesting to remain connected with you all and hear how you all have been able to possibly incorporate this change model into other areas of your agency work and how that has been able to help sustain sort of the progress that you all have seen with your heart disease and stroke work. So ASTHO will definitely remain in contact with you and work with you on ways to promote how you are continuing to utilize this model. So that is an overview from our national partners and a reminder from ASTHO on sort of the framework of our Million Hearts work, but we definitely do not want to part with you before we're able to showcase some state and local level examples. So without further ado, I'll now turn it over to our Wisconsin team. Mary and Rebecca, can you all hear us, and can we do a sound check with you all?
Sure. This is Mary.
Great. We can hear you just fine. So I'll now turn it over to you, and just let me know when to advance your slides.
Great. Thank you. Well, first, I really want to thank ASTHO and the other national partners for the opportunity to share kind of our Wisconsin story, and then also certainly for participating in the Learning Collaborative. If you want to go to the next slide. Thank you. So really our approach to kind of Million Hearts as, in Wisconsin as a kind of a blanket overarching goal is to build on a lot of different initiatives and programs that already exist. Certainly our participation in the Learning Collaborative, our 1305 State Public Health Actions Grant, Coverdell, our WISE one. We have Million Hearts Wisconsin Steering Committee and Committee. We have a long-standing Heart Disease and Stroke Alliance that has existed for probably 10, 15 years. There's efforts around the state innovation model. We have our Wisconsin Health Improvement Planning Process, which is our state health assessment. And we're also the state health department and many of our local health departments working on public health accreditation. So our approach really to hypertension identification and control has been to look at, the different components of all of these initiatives and programs and build on them, taking kind of the strengths and assets. And, many of the same partners that are participating in one program are also participating in another. So we've been able to leverage a lot of different resources, both, a lot of in-kind support, volunteer work, other, material development, website hosting, et cetera, as well as, kind of that putting some financial resources into the mix through all of these initiatives. I think when we look at hypertension particularly and the group of patients and people that are kind of the hiding in plain sight are those with undiagnosed hypertension. I think when we started working on this, a year or two ago, the first thing we really needed to do is kind of create some awareness that that was a population that actually existed. Most of the effort until that point had focused on people that were uncontrolled or in control, which we were doing really quite well with, I think, across a lot of our health system partners. But when we started talking about, there's a group within your health system that probably isn't identified with hypertension, there was, a little pushback in saying that those don't exist or there's a whole lot of reasons for that. So I think participating in the Learning Collaborative has helped us do some of that identification and awareness building that this really is a population that exists. So I'm going to have Rebecca talk about the 3 learning sites and show you how we did that.
Good afternoon. Hi, it's Rebecca Cohen. And our project has 3 sites, as Mary just said, and West Dallas is located in Milwaukee County, and the West Dallas Health Department works minimally or just worked across the city municipality with our community health center, 16th Street, which is a federally qualified health center. And the community health center has had community health workers as part of their efforts to work in the Hispanic Latino community, as did the West Dallas Health Department, had community health workers or promotoras. And these 2 agencies, the community health workers, knew each other and had worked together, but not across the lines to focus primarily for our project on hypertension and the hypertension screening that was being done in the community. So the project really helped to foster bringing the groups together, and they really developed referral protocols and resource materials that were developed in Spanish as well as in English. And the health department staff also, along with the 16th Street Community Health Center, used the quality improvement process to really look at the efforts in the workflow and the bidirectional processes that could be improved to engage the persons in the Hispanic community, to get them connected through the, after the blood pressure screenings, to get them connected to care that they needed. Also, West Dallas developed and strengthened their own protocols for blood pressure measurement and engagement within their WIC program and home visitation program. Through this project, we also asked the 16th Street Community Health Center to work with their data people to implement the algorithm to find those undiagnosed or those hiding in plain sight within their EHR or the EMR. Next slide, please. In their work that they were able to apply with the algorithm, they did identify 84 patients or that were within their system that did not have a diagnosis of hypertension, but they did indeed have 2 blood pressure readings that were elevated. So they, as a health center, have added hypertension as one of their community clinical focuses. And we just spoke with their community clinical coordinator yesterday, and they're really focusing on using the analytics to further go into their records, to apply the information that's needed from the medical visits, and to move that forward. So there'll be more information about this process and hypertension as it unfolds for this FQHC. And part of the spread and sustainability and growth is we're hoping that we have 18 FQHCs in Wisconsin, that 16th Street can be a model and help to work with the other FQHCs. The other piece for us that has been beneficial is that West Dallas has been able to share their screening protocol with some other health departments in the area, and we hope to have them champion their protocol across the state with other local health departments. And also, through this project, we've been able to, again, start the conversation with some other health systems in that area. Next slide. Greene County is located in the rural part of Wisconsin, and this particular county department is, excuse me, had been working,
So, Rebecca, I had a little cough. So Greene County had been working with, their Monroe Clinic, which is kind of the one main health system in their area, and some other nonprofit agencies. So they were able to, I think, kind of transform a little bit the role of the health department into that kind of chief health strategist role. Bringing in, the public health nurses, the parish nurses to do the screenings, but also I think develop those referrals and protocols that they were using. I think one of the things, and you can go to the next slide, is that is really exciting is that there was a community coalition that really wanted to take ownership. They were the coalition that had kind of participated and led their community health needs assessment, and so they've really come on board, and so they've created an agreement with over 50 partners signing up and participating in that. They have a website now that they're using to post the protocols that were developed through the project, so that it can be available to a number of other health professionals like schools and dentists and others, EMT hopefully. They've also developed this community resource guide, and then there's an agreement, with Monroe Clinic and others to look at this protocol again. I think the other exciting piece that's kind of emerging is that there was a real gap within this rural health department of the ability to have electronic medical records or electronic capabilities for bidirectional referrals. And so we have Epic is in our backyard, and particularly in Greene County's backyard. So with Monroe Clinic and the health department in Epic, they're discussing some ways to give access to a basic level EMR to the health department to build that capacity. So that's been exciting. Next slide.
Thank you, Mary. As Mary mentioned, Monroe Clinic has been one of our key champion partners. And Monroe Clinic, through our project, was, as an agency, identified hypertension as one of their 2016 quality goals for focus. And through this project, again, they had trained their staff on how to take accurate blood pressure measurement because they realized the importance of that. And they also, through their community clinical linkage team, realized that they needed to take a population health improvement approach. So this project kind of came at the right time, and so with looking within their system, they were able to put in place a triage nurse, again, to help link patients to supportive services and care for hypertension. They hope to also look within their EMR to identify those patients hiding in plain sight. They use the Million Hearts estimator for year 1 and now for year 2. They want to move forward in doing some more of the algorithms and looking at their patient population. As Mary said, again, they are an Epic system user, and they were able to connect the health department with Epic. And we're really looking forward to the efforts that this project will hold for that local health department, as well as building an access between the agencies at the community level. Next slide, please. The City of Milwaukee Health Department has its men's health program, and our project helped to really bring in the fact that Milwaukee Health Department worked with many health system partners and many community partners, but the relationship for our project was in need of support with bringing in some of the health system champions. So the Milwaukee Health Department, in collaboration with the American Heart Association, their program Check Change Control, refers men that had high blood pressure readings to this Check Change Control program. And the program was also located at the Metro YMCA, so it was really embedded right in the heart of 2 zip codes in Milwaukee. And so the lead at the American Heart Association also provided the advocacy efforts at the local level. And through a community gospel concert, which is a very big event in Milwaukee, they were able to hold community screenings and to identify people that might be potential recruits for the check change control program. Next slide, please. Well, in bringing all of these partners together, we needed to look ahead to year 2 for sustainability. And in this north side metro area in Milwaukee, a local clinic site had just opened up, and it's very close proximity to the YMCA. So they are going to, for year 2, be collaborating in the check change control program, and will offer access to care for some of the participants that may need it. We also, through this project, have been able to bring on some additional health system connections. One of our champion cardiologists asked within her health system if they would be able to work with the algorithm to identify persons hiding in plain sight, and she just received word yesterday that they're a go for the program. So again, this is great to bring in more connections and to work in this area. Also, additionally, for sustainability, we have been able to bring in a local pharmacy, and when I say local pharmacy, it's locally driven, but there are several pharmacies, and Hyatt Pharmacy is a leader in the Milwaukee area, and they are very interested in working in providing support to the patients or the clients in the check change control program. So that again will be an added benefit to the participants in the check change control program. The Milwaukee Health Department also has been able to share its screening protocol with other agencies and other health departments. And again, through this project, we are working towards sustaining the efforts. We will be presenting to the regional offices the work that we're working on in this project with, again, promoting the blood pressure screening protocols. And again, talking about serving diverse communities in the Milwaukee area. We're also working with strengthening the connections with the community health workers and the health coaches, which are part of the check change control program. And also we've been able to provide training to all of the sites on better serving participants through motivational interviewing and offering blood pressure accuracy training. So we're really looking forward to promoting the work in the 3 sites across the state.
Next slide. So these are hyperlinks to a number of resources that either have been developed, as part of or informed by the ASTHO Learning Collaborative, or some of our other work. So I want to just share those so you can check those out. And then next slide. And so a few next steps. We really want to package the protocols and tools for dissemination and replication statewide. I mentioned accreditation at the beginning. I think this was one of the aha moments with our local health officer, was that this is a really great project that could be used for evidence for accreditation. So we'll also be working with them to help that come true. As Rebecca mentioned, there's a lot of partnerships that we want to continue to expand on and sustain over the next few years. And then I think continuing to look at where we can leverage other resources, both financial and other, to continue the great work that we've started. I think there's a lot of momentum here. So I think, again, that was a great outcome, or maybe unintended outcome, of the Learning Collaborative. Next slide. So here's a picture of our Million Hearts Learning Collaborative team. So you can get some of our smiling faces. And then next slide. this is our contact information. I know we threw a lot of information at you quickly, so if you have any questions, feel free to reach out to either myself or Rebecca. Thank you.
Great. Thank you for that presentation, and I have been taking note of the questions we've been getting in the chat box. I will reserve those until after Lance's presentation, and just a few highlights of some communication materials that have been recently developed related to this work, and then we'll move into our Q&A portion. So keep putting those questions in the chat box. I will now turn it over to Lance in Texas. And remember to press *7 to unmute your line.
Okay, can you hear me?
I sure can.
Okay, good morning, or good afternoon. Okay, so I want to talk a little bit about what we've been doing down in Texas. And I just want to start off by saying this was a really useful program that we were able to participate in, and so a big thanks to ASTHO. One of the things that I really think was important was, you know, when you talk about population health and some of those initiatives, it can feel like you're boiling the ocean. But for us to focus on hypertension and uncontrolled blood pressure, this really helped us be able to make some real tangible movements towards getting this under control and helping out our entire population. So in Texas, we did not expand Medicaid, and so we still have a lot of people who are that just do not have the access to medical providers or to medications like they should have, and so that creates a unique challenge for us here. And so through this program and through some of the collaboration with our partners, we've been able to kind of advance the ball, so to speak, in terms of getting these people access and getting some of these people getting their hypertension under control. Okay, can we go to the next slide, please? Okay, so one of the things that was really important for us in Texas was I got invited a little bit late, but ASTHO came to Texas, to Jasper, and we had a kickoff meeting down there. And this was really an opportunity for everybody to get in the room and to brainstorm ideas and to really share what kind of problems they were having around this hypertension. And so we included a lot of people. The health district was well represented. We had some elected officials there. Our local FQHC was there. Of course, I was there representing the hospital. We had some physician practices that had representation there. And there was a number of others, but it was really nice to see that everybody was dealing with the same situation, maybe in a different way, and maybe they encounter these patients at a different point in the healthcare continuum. But it really made, or it really tied together that everybody was dealing with the same problem in different ways. And so to get that out there, to hear other people speak about the problems that uncontrolled hypertension was posing to them in their work areas was really helpful. It helped me to empathize with these other providers as well from a hospital standpoint. And so it really kind of lit a fire under me to give the resources that I had to this program. And I think we made a lot of progress, and we'll talk about that here if we could advance to the next slide. Okay, so one of the questions that we came up with are why are these patients either becoming or continuing to be hypertensive? And we found out that there was a real lack of education just regarding the disease. And so, you know, we have patients putting sugar on their Fruity Pebbles and just making really poor nutritional choices. And so one of the things that we did was partner with the local health department and the AgriLife Food Extension Program, and to provide some free education to patients that came through our ER that were indigent patients, and that we were able to send out to either FQHC or the health department, depending on their payer source, and say, hey, this is a really good resource for you, and this will be helpful for you to understand the disease process and how your food choices play into the continuation of that disease. So the local the local health department also, as they had patients come through and see their nurse practitioner and their providers, they would also make referrals to this program, and they had weekly meetings where this resource would be available to really help people figure out how their food choices were affecting them, and how their their access to medication was affecting that as well. So the second bullet point down there was access to medication. We had a real problem, especially in our emergency department, where patients would come in, we would control them, or attempt to control their blood pressure there in the ER. We would write them a prescription and discharge them, and then they would be back in just a matter of weeks or months or whatever it was. And really it came down to they could not fill their prescriptions. So we had a real problem with people saying, I have to make a choice between food or other basic necessities and prescriptions. And of course, when you're making that decision to feed your kids or buy your medication, you're probably going to feed your kids. And so that was a huge problem for us. And so a couple of the things that we were able to identify, some solutions we were able to identify was there's a lot of prescription assistance programs out there. And so that would kind of be our first resource that we would look at, as long as they qualified. And so so what we found was there was still a gap, and people were still having trouble getting those prescriptions and getting on those prescription assistance programs. So one of the things that we identified was we participate in 340B, which is a prescription program that if you qualify as a rural hospital, which we do, and you provide so much Medicaid, you can have access to deeply discounted medications. And so we are right now in the process of implementing a 340B retail pharmacy in our hospital, and we should be able to open that up in January. So what that will allow us to do is really prevent a lot of unnecessary admissions to our hospital through the ED, because these patients are reoccurring in our emergency department with things like hypertension, and it's for lack of medication. So we can provide these for very little cost, which will be a great benefit to our community. Okay, can we go to the next slide? All right, access to providers. So once these patients were controlled in getting their medication, they really needed to make sure that they could go to a provider, that these things could be explained to them. And so we put in our emergency department a community health worker. And that was really important because they could navigate and help these people navigate all of the resources out there. So if they were a certain income level, or they had certain resources or certain insurances, they were able to kind of send them out to different providers. So we have rural health clinics, which is a good resource. If they were part of our indigent care program, it didn't have any payer source or anything like that, we could send some of those to our rural health clinics. We reached out to the health department, and again, depending on their income level, they may have qualified to go there, or to our local FQHC. And so that community health worker really did a good job in sending them out there to providers and finding people that would take these patients, and then also navigating through the prescription assistance program. The other thing that that came up was with our Texas Hospital Association, and they provided a lot of resources, and they are in fact putting together a program that will that is a community pharmacy program. And so what this will do is be able to get through a patient enrollment, they will enroll in this program, and then physicians can refer these high-risk patients to these network pharmacists. And so during the initial appointment, the pharmacist will identify adherence barriers and figure out what is preventing these patients to adhere to their prescriptions. So with the patient, the community pharmacist will get a medication action plan, get it implemented and developed, and then if there are therapeutic drugs or they're just not feeling well, that pharmacist can make recommendations back to the physician, and then the physician through their electronic platform with a single click can either accept or decline those recommendations. And so that's good because a lot of the times our patients are going and getting, I guess, more educated speech from the providers and not necessarily understanding exactly why they need to take this medication or they don't feel comfortable giving feedback to the provider. And so this is a great opportunity for our local community pharmacists to help out in this process and make sure that the drugs that these patients are getting are therapeutic, that they're at therapeutic levels, and give some feedback that they may, in a setting that they may feel a lot more comfortable with. So we're anticipating going with that in either January or February, and so we're excited about that as well. If we could go to the next slide. Okay, so in conclusion, I want to stress how important our kickoff meeting was to get everybody in the group, to get some of those relationships started, but also to understand other people's problems and how their problems may translate into my problems or vice versa, and how we can work together to help each other out. I would really emphasize or suggest that you include elected officials, county commissioners, and that sort of thing, because a lot of times they have skin in the game for indigent care programs, and so they can either bring resources or help coordinate other resources that will really help out. And then organize efforts that work towards some sort of common goal. Everybody, I think you can identify 1, 2, or 3 common goals and really work towards those. And then I think we heard about this earlier, is just get a standing meeting going. We had space at the hospital, and it was easy for everybody to come there, grab lunch, and then have a meeting. And timing was really important for us. So we wanted to make sure that we met often enough to where we could continue to make sure we had the ball rolling and things didn't become stagnant, but not so often that you couldn't get things done in between those meetings. But like I said, this program has been really helpful for us and our patients, and we have made some really positive impacts towards population health and getting hypertension under control in our communities.
Great. Thank you so much, Lance. That was a wonderful, wonderful presentation. I really appreciate that, and I also appreciate all the questions we're getting in the chat box. I want to encourage you all to continue to add those questions there. I'm going to turn it over to my colleague, Lynn Shaw here at ASTHO, to share a little bit more information with you all related to our project, and that'll give you all some time to type in your last-minute questions before we turn over to the Q&A portion. So, Lynn Shaw?
Hi, yes, good afternoon all. So just a couple updates on ASTHO's end. So ASTHO has a Tools for Change website, as you all have known about for a while now, but more recently it became a searchable library, so much easier to navigate and use and send to your partners to use as well. So that has many, many tools and resources from the states we've worked with, as well as our national partners and federal partners as well. And so you can search by topic, by resource type, as well as by state or territory, and it has over 300 resources to date. And so when we go through your final reports, we put those on the website, applications that come out either on ASTHO's end or our partners' end, we put in there. So we have 300 so far, but it is a growing resource. So if you're looking for something there that you cannot find, let us know, or if you have something that you think should be featured, please let us know. And it is available online on that website. And on the next slide, just a quick screenshot just so you can see what it looks like, and again, the URL. And then on the next slide, we have just featured our most recent publication, which we are calling a booklet, but needs something a little bit more exciting. But it is a sort of 10-page, tiny booklet that talks about the ASTHO systems change model. It has some state stories. It also has some aggregate outcomes and lessons learned that we've learned over the past 3 years in doing this work. So encourage everybody to take a look at that. It's on our website. We think it's a good way to show partners and especially leadership in your state sort of what you've accomplished as being part of this learning collaborative. And this is the first of many sort of outcomes-based products that we're working on with a communications firm to really highlight your success. So if you don't see your specific state featured in that, do not worry, that is coming. This is the first of many, and just encourage you all to share this with your partners. And we're also mailing these in the mail to your health department so that you can share the hard copies themselves with folks. And in the meantime, feel free to visit that website, and you can just print them out that way as well. So I think that is it. Yeah. Thank you so much again, and I'll turn it back to Alicia.
Great. Thank you, Lynn. So now we are at the final part of our webinar today to address any questions that have been submitted. We have about 11 minutes, so that's plenty of time to get enough of these questions answered and also to take a few more. I will start out with Pamela's question, which was directed at Wisconsin. So Rebecca or Mary, if you could respond. She wanted to know, would you all be willing to share the data algorithm that you all use to identify your undiagnosed hypertension population? And you may need to press *7 again to unmute your line.
Can you hear us now?
Yep.
Great. Yeah, we would be willing to share the algorithms. Should we send them to you, Alicia, and then you can send them out?
Sure.
Or if whoever asked the question wants to send us an email with the information that was on the screen, we can send it to them directly.
Yeah, either way, feel free to send it my way, and I can shoot that out to all of the participants with the post-meeting materials. But certainly I'll put your email address back up for them to see. If Pamela, if you're still on and you want to email them directly and get that, their contact information is there. So thank you. So next question comes from Valerie, who wanted to share that one of their challenges with CHWs that they've had is re-engaging identified risk individuals after their first encounter. And so they're wondering, has your program been successful in following up with individuals to ensure that they're actually compliant with the recommendations that they receive from CHWs? So either, I think it was directed at our Wisconsin team, but Lance, if you have anything to add, feel free. So Rebecca or Mary?
Well, I mean, I think that's part of the work with the community health workers is that, you know, they'll continue to kind of follow up with them. So I think we, you know, found particularly like with our check change control program in Milwaukee that, you know, between the community health workers and kind of the class structure of that program, that, you know, they had pretty good attendance and follow-up throughout, but it did, you know, some people took more than that, and then good results of getting people from kind of the undiagnosed to diagnosed and moving into control. So I think that's where kind of the uniqueness of the community health workers and, you know, and our other sites with the, you know, parish nurses and things, that they were able to do that follow-up in kind of different locations, so kind of go where the person was rather than having them needing to come back into a clinical setting. So I think that's one of the lessons that the sites learned, is that need to have lots of opportunities where people can go to get their blood pressure checked so they don't encounter you know, co-pays and other kinds of things that they might encounter if they have to go back into a clinical setting.
Great, thank you for sharing. We received another question. I think this is more broad. So for our national partners, for those of you that still may be on the line, if you all have responses to this, I think it'd be helpful for you to also chime in. But Jessica asked, has there been any talk about working with EMR vendors on developing a national strategy for hypertension identification and control that would automatically become part of the system without having to work with individual localities. I think this might be on everybody's wish list. So we're waiting on Santa or whoever we believe that brings our gifts every year. But if anyone has any insight to contribute as far as a response to this question from our national partners or our state and local folks, speakers that were today, please press star 7, unmute your line, and provide any insight that you might have. Anyone?
Well, this is Mary in Wisconsin. So one of the items that I had linked to is that we did a bit of a landscape assessment to identify, potential software. So it's the, which one is it? The linking clinical delivery to community resources, a landscape assessment. So this was a limited kind of snapshot of different, kind of population health tools that have that ability to do some linking between a community location or community agency and the kind of more clinical EMR. So, I think we're having that conversation. As I mentioned, we have Epic in our backyard, so trying to get them. So like you said, it's on everybody's wish list. I don't think anybody is quite there yet, but I think it's starting the conversation, and things seem to be emerging a bit.
Yeah, I agree. Any further comments from our national partners on the line? Okay. So there's one more question in the chat box that actually came from our partners at NACDD, and I believe it was directed at Lance during his presentation related to an assessment. So the question was this an assessment they did on patients, and where did this information come from? Julia, can you unmute your line and share with us specifically what you were referring to in your question, please? By pressing star 7.
Can you hear me?
Yes, we can hear you.
Oh, sorry, I was talking. I thought I was off mute. There was information shared that they found a lack of education regarding the disease process, that there was also access to medication was an issue, and access to providers, like really good information. And I wasn't sure where that information came from.
So Lance, can you respond to how you all identified that those were the challenges among your target population?
Yeah, sure. So one of the tools we used was our community health worker, and so as we would see people come back through the emergency department for the same chief complaint, we would conduct an interview, and so they would get a lot of feedback, a lot of stuff saying, well, I didn't know it was important for me to take this medication, or I had to choose between this and this, and so I didn't buy the medication, and that sort of thing. We also went to our rural health clinics and talked to our providers there, and got a lot of the same information about, we just did not really understand that, our diet was impacting this. And so we just got a lot of feedback from them. There was no scientific method of getting that to where people were providing that information. But it was just, we had so much feedback from our community health worker and our providers in our rural health clinics that it was just abundantly clear that these people were having trouble getting this medication, and they didn't really understand the consequences of not really adhering to that medication plan that the providers gave them, or even just getting that prescription filled.
Great, thank you.
Thank you. And we have about 2 minutes left, so maybe time for one last question. This question comes from Danielle, who shares that one of their challenges is providers and nurses really don't see the value and community health workers and are not willing or ready to work with CHWs. Her question is, have you experienced this? And if so, how have you overcome this barrier to get provider and clinical team buy-in for CHWs? And that question's for either our team in Wisconsin or Lance in Jasper, Texas.
Okay, I'd be happy to answer that really briefly from our point of view. Especially in our emergency department, it became very evident that the community health worker was making a big impact. We started getting referrals from our physicians in the emergency department to our community health worker because they just saw the value in the ability of a community health worker to communicate with a lot of patients, and I guess they just felt like they weren't quite getting through because we kept getting the same results. Here's your prescription, go get it filled, and then they were back 3 weeks later with uncontrolled hypertension and that sort of thing. So a lot of just clear evidence in our emergency department that those providers grabbed a hold of. I went and took that and explained that to our providers in our rural health clinics, and then they started making referrals to our community health worker. So it wasn't really hard to see the impact, but just getting them exposed to what a community health worker can do. Time is really important to providers as well. And so when you can explain to them, hey, you don't have to spend 45 minutes explaining to somebody why this is important. You can, do the plan of care and then in concert with a community health worker, get these people onto it. They see the big benefit so they can get on and see more patients.
And this is Dee from Wisconsin with the Check Change Control Program. And I think community health workers come with more authenticity sometimes, and that is built because they have longer time to have those conversations and truly listen. And when you get community health workers who are from the community and of the community, there's an opportunity to listen from their perspective and make sure that individuals are leaving with their questions answered. There's still so much intimidation when you're in a healthcare setting for individuals, especially from underserved populations, be it minorities, low income, or even in rural settings, that when you come into a healthcare setting, we almost act as if sometimes going back into a child mode, fearful of asking anything, fearful of people realizing that we have literacy issues on top of health literacy issues. So a community health worker truly can help bridge that gap and help them to navigate and feel comfortable asking those questions. When you're working with families who have multiple languages in a home or, in a clinic, you're seeing different immigrant populations. Sometimes even on our best translators, just one little word can change the entire tone or delivery of what you're trying to say. So when you have people who are truly from the community and they know those different social determinant issues that patients are facing when they come into a clinic, it helps for them to feel comfortable explaining, I was feeling better, so I stopped taking my medication, or, I was feeling fine before I came here, then you guys diagnosed me with hypertension, put me on medication, and now I feel awful, and that's why I'm not coming back. They need someone that they can talk to and feel like they can voice their concerns or their questions and helping to be the bridge.
Wow, thank you guys for those final comments. That's very helpful. And I realized I got an additional question in the chat box, but we are at time. So what I will do is connect you all virtually via email to get that answer to your question. But thank you all so much for spending some time with us this afternoon to hear about the great work that's been going on. I really hope that it is beneficial to the work that you all do. If you all need further information or want to be connected to anyone who you heard present on today's webinar, feel free to reach out directly to me or any member of the ASTHO team, and we'll do that. But you will receive a copy of this presentation as well as the recording. Thank you all for joining us today, and have a good afternoon.